Hello, everyone. I'm Allan Brandt, and it's really just very exciting to welcome you to this new course, Gen Ed 1170, Confronting COVID-19. It's a very unusual time for all of us. Many of us, like me, have never taught in a remote situation. I really wish there was the chance to walk into a classroom and see you all at this time. But as you know, we're living through an epidemic, and that essentially is what this course will be about. I'll say a bit more about myself in a minute, but I want to introduce my colleague and the co-instructor in the course, Dr. Ingrid Katz. Dr. Katz is a distinguished infectious disease specialist and an expert on global health. And let me turn it over to her for a minute, and then we'll tell you a bit more about the course and some of our thinking that went into planning it. Dr. Katz.
Thank you so much, Professor Brant. We are so thrilled to welcome all of you here today. We know this is such an unusual time, and we are going to be living this together. We're so thrilled to be walking through this moment. We have an amazing group of over 75 faculty that we are so excited to bring to you. And we hope that even though we're in this very unusual format together, that we can really engage you in this conversation. And we really do want this to be a conversation with you all. I'm going to turn it back to Professor Brant as we walk through all of these pieces together. But I just really want to welcome everyone to this space.
We thought we would just tell you a little bit about how this course got going and our planning and thinking that really underlie the foundational objectives and goals that we have. And Dr. Katz is, among other things, the Associate Faculty Director for the Harvard Global Health Institute. And she and I were meeting in early March. And by then, the impact and implications of the epidemic, not only globally, but in the United States, were becoming just a bit clearer. Most of you who are upper class people were still on campus doing your spring term. And when we met, we started thinking, well, this might really be a moment to do a course in real time as the epidemic of COVID-19 unfolds. Little did we know, a week later, all of you would be sent home. We would be sent to remote locations, and we would begin to work in radically different ways. It was hard to tell early in March when we first met anything that would transpire and how we might do it. But as we thought about it and as we went remote, we thought this is just a remarkable time to try to think through a pandemic that is happening all around us. And, you know, we've all struggled, I think, over these last 6 or 8 months to try to figure out what is going on, how is it changing the way we live, how is it changing the work we do. For all of you, how will it change your college experience? How is it changing life in hospitals, such as the Brigham and Women's Hospital, where Dr. Katz works? How is it going to change higher education? And then literally hundreds of other questions about what the impact of the epidemic will be, but also what should we be doing now? So Yvonne, if you could just hit the next slide. So we developed a series of objectives for the course. And we obviously want to explore what we will call, and I'll say a bit more about this later in today's session, the biosocial characteristics of disease. Obviously, COVID-19 has a unique set of biological and pathological characteristics. But one of the things that seems so obvious to us now is just how many different social impacts it has and how the social response to the pandemic, public health and public policy, will also shape the biological characteristics of the epidemic. So we'll be going back and forth quite a lot between the integration of biological and fundamental social variables. We want to see how the epidemic will change cultural practices and institutions. And we're very hopeful that all of us, and especially you, will develop skills and insights into not only how to understand what's going on around us at this critical time, but how to think about advocacy, reform, public policy, social justice, all as the epidemic has represented them, and as we still have a chance to potentially make a difference in the outcomes surrounding COVID-19. Let's take the next slide, and I'll turn it back to Dr. Katz.
And I just want to reiterate that this course is meant to speak to a broad range of interests, whether you're a first year or you're a fourth year, whether your major is in English or in the basic sciences. And we have really been so thrilled to see the exceptional expertise we have here at Harvard across all of these disciplines. As you can see on this slide, this is just a very small sample of some of the faculty who will be coming to speak with you during this time. And we have been so thrilled to see the diversity of faculty across the university who really pivoted from whatever they were doing 8 months ago to really focus on COVID in this moment. We will be speaking with professors from the School of Public Health, all the way across to the Ed School, to the Kennedy School. We'll have faculty from all of the hospitals. We will have basic scientists. We'll have academicians who think about the impact on race and society. And if you've had a chance to dive into the syllabus a little, you'll see the incredible breadth of expertise we have. And that's one of the really miraculous things about Harvard University. It's so vast, and we have such broad expertise across so many areas. So this isn't a basic science course, but nor is it an anthropology course. This is a course that's going to combine all of these people together to offer this cross-disciplinary expertise and really get to that 360-degree lens as we move across. So you can see here we have 10 schools, 22 organizations outside of the university, and 31 disciplines. We are set up so that we have this introductory session today to give you a sense of the overarching view of the course. And then from here forward, we'll be having 3 to 4 guest faculty in each session. Professor Brant and I will be with you for the entire journey, and we'll be introducing speakers and having conversations. And our real hope is that we'll invite you into this conversation as well, both of course through your sections, which we'll get to in a few minutes, but also in the context of these lectures. That's why we've chosen to do these lectures synchronously as opposed to asynchronously. We know how everyone is spread out right now around the United States and maybe even around the globe. And this is a chance for us to come together twice a week and be connected to one another as we explore this moment together. So I'm going to hand it back to Professor Brand, and we can move to the next slide.
Let's hang on to this slide for just a second,
good.
Because I just want to reiterate several things that Dr. Katz just said. I've taught for a long time in the college and the arts and sciences. I also have an appointment at the medical school where I teach in the Department of Global Health and Social Medicine. And one of the things that has frustrated me as a long-term Harvard faculty member is that typically undergraduates are not in a position to take advantage of the remarkable faculty across Harvard University, in the many professional schools and the graduate schools. And it's very difficult. Very often I would want to give a course with a number of visitors, and I would call up colleagues and friends, and they would say to me, but there's no parking in Harvard Square, and it'll take half my day to come over and talk for 20 minutes. And I'd love to come, but I'm busy in my laboratory or in my teaching in another faculty. So I don't believe that there are silver linings in pandemics, but I would say that our ability to bring together so many people from so many disciplines is one of the possibilities that the remote platform has really produced. And the other thing I would say is faculty really understood when Dr. Katz and I invited them that this was a chance that they often are seeking to interact with undergraduates, which many people on the Harvard faculty so rarely get a chance to do. So these are really unique aspects of the course. The other issue I would underline is the range of disciplines that our visitors will represent, because everyone knows that there's no single discipline that can put their head around a pandemic, that inevitably pandemics demand attention from virtually every field we could think about. And it would be difficult under other situations to have such a broad interdisciplinary group of scholars who are typically working away in their specific field, but now have a chance to engage across many fields with you. So these are aspects of the course that I think you'll see play out, but I think we both feel are characteristic of what we're trying to accomplish during the term. Let's go to the next slide, Ethan. Either one of us can pick up on this. I'll just say first that the readings are central to the course. They've been changing by the minute. It's a very unusual situation that most of what you read in this course will be produced maybe as recently as yesterday or today, but certainly in the last 6 or 8 months. The amount of scholarship and media coverage and different media for reporting out COVID-19 has just been amazing. It's one of the stories of the epidemic that we want to take up. So we have produced a reading list. There may be small changes, but I think you'll find the readings diverse, and I hope of the moment. Your ability to integrate readings and these presentations twice a week will be one of the critical aspects of the course. Dr. Katz, you want to?
Yeah, and I think also part of this, so we will have these readings that we are, as Professor Brandt said, very excited to share with you. We'll also, the thread as we have this conversation with our guest faculty, because this history is being written real time, we'll be sharing ongoing materials more in a conversational way to stimulate discussion and to be speaking to all of us real time. There's going to be a lot happening this fall, and we'll be living that together. So we want to make sure that we stay current throughout the course. And so we'll be discussing those with you as well as our guest faculty based on each session. We'll also have these weekly response papers. So as you can see here on the slide, each week you will submit a one-page response to one of 2 questions that we'll pose to you about the course readings. These are due on Monday nights and should be submitted through Canvas. And this is, again, just a way to have this conversation together. We're really very invested in speaking with you. We know that you're all experiencing this in your own world wherever you are. And so we want to hear from you, especially in relation to some of the readings that you're going to be having together. I'll turn it back to you, Professor Brandt, for the podcast.
Thanks. We went through a lot of discussion about how best to set up assignments for the class and what a capstone or a major assignment would look like. And eventually we hit on the idea of all of you doing a podcast. And I realize this is challenging in some ways because most of us, certainly I have never made a podcast, and I assume most of you haven't. But the logic of doing it seemed compelling in this way, is that we're living through an epidemic and we want to learn and understand it better. but in a sense, we're also deeply part of this moment. And I often find myself as a historian thinking, well, how would I look back at 2020 from 2100 and what people were experiencing during this first year of a global pandemic? And what kinds of materials would I use and how would I think about it? And we realized that all of you have a chance to capture a real life element of that by interviewing people and telling their stories through a podcast. And so in this way, and I have to say I've been very committed to this in my teaching over recent years, students aren't producing work for me or Dr. Katz or our teaching fellows to evaluate. They're producing something that will be of value to others socially, historically, culturally. And so we had this notion that if people did podcasts, and we'll say a little bit more about some of the process and topics that one might do in a minute, that these would also have the possibility of memorializing in some ways what this first year of the pandemic was like, especially for all of you scattered in different places. And I would imagine that there will be similarities in terms of the kinds of projects you might take on, but also recovering a certain kind of local cultural artifacts that will someday be part of an archive. And we're hoping that the work that you do in the course will be part of Harvard's archives and part of the record of the epidemic, at least from this particular moment. So we're really quite excited about that. We want to make sure that you have the opportunity to hear each other's podcasts. But we really think this is just the right type of assignment for such a complex and important moment. So, Yvonne, next slide. So this is just a crude outline of the percentage that these various assignments will be the metric. And if you have questions about that or anything about the course, of course, feel free to ask me or Dr. Katz or our head teaching fellow, Michelle Labonte.
So maybe we should hand it back to Professor Brandt to speak a little bit about some of the history of pandemics.
Great. We can go to the next slide, Yvonne. Thanks a lot. I have to admit, I've been thinking a lot about this, and in some ways I've been working on epidemics and epidemic disease, how to think about epidemics, disease, and illness through my whole career. And I really started out as a graduate student in American history with the idea that history had really focused on elite people who left great records, and that a lot of us really wanted to understand how people had lived in the past and what was the nature of the life of common people in communities, in families, in towns and cities. And so a group of historians, and I would consider myself in this group, began to think about problems of health and disease and how revealing they are of so many aspects of human life, and that all of us go through periods of health and or illness, and how we think about them, what causes them, what to do when we're sick, who takes care of us. These are among the most fundamental historical questions, but also not so easy to observe and understand. And these processes of health, illness, disease, epidemics, social and public health responses occur frequently in history, but it's sometimes hard to see how people experience those threats and sometimes emergencies. And so a group of us started looking at things. We wanted to understand aspects of childbirth and gender, sexuality, and how race and racism affect human health and disease. And this has been an ongoing project for a group of historians of medicine and public health now for a number of decades, and has shaped things that I've worked on. But there are a set of questions usually when you observe disease or you observe a pandemic. Where did it come from? Who will it affect? Who's really at risk? Who might be safe? How sick will people become? How many will die? What are the approaches to trying to address sickness and death in any given moment? And these are, in my mind, profound human questions, and a lot of us have written about them in the past. But as Dr. Katz said, we're really going to do, in a way, the history of the present in this course. But I'm convinced that the questions that this group of historians, and I've been trying to ask for a while, are relevant in sharpening our thinking about the COVID pandemic. So all of these questions of risk, uncertainty, social impact, economic impact, political impact are crucial to the way we'll be approaching thinking about COVID in the course. Yvonne, can I have the next slide? One of the claims that is characteristic, and I actually looked up biosocial early this morning and realized that it means different things in different fields. So I want to be clear how I'm using it and we'll be using it in the course. But this idea that health and disease are essentially at the interface of our social and our biological lives. And they really can't be separated. They can't be easily differentiated. And the way we take care of one another socially has profound effects on our biology and our health. And our biology and our health obviously have profound influences on the social. So a number of people working in fields like my own of social medicine and social history of medicine have often utilized this term biosocial. I'll take the next slide. But they also use terms that are related in a sense that try to integrate what in some ways we think of the qualitative social sciences like anthropology, history, literature, with these fundamental biological shifts that happen historically and in societies. So some people will talk about the biocultural and the way cultural change actually affects the body. And many people in recent years have talked about the biopolitical, which in a sense looks at the way political systems affect humans and their health and how they're disciplined or incarcerated or subject to the vicissitudes of class status or racism or ethnicity. And inevitably, I don't think one can look at COVID without thinking about the biopolitical. And then there's also the term, and some of these terms are more precise, but they often get used interchangeably, what we refer to as biopower. And this is a term that was coined by the great French philosopher and historian, Michel Foucault, but it really refers to the notion that the state and governments have profound impacts on the biological context of our lives and profound differences in health and disease, work and labor that all have an effect on how we live and our biological and human vulnerability. So all of these things seem to me to be at stake in how we will think about COVID-19. And both Dr. Katz and I will be pushing to not only sort of identify the problems in COVID-19 and the responses to it, but to see these issues in this broader theoretical or social way. Next slide, Yvonne. So people are asking, what are the characteristics of historical epidemics? And people in the media rarely call me. I haven't been on television or on cable news a lot, but suddenly people like me found ourselves getting calls in February and March, especially March and April. What does the history of epidemics tell us about the current moment? And these sort of discussions went two ways. One was, well, there've been a lot of epidemics and we can learn from them and understand what happens, or epidemics are always different. But there are these, ramifying characteristics of watching people and understanding what's going on, how to respond, what it means for them, what it means for their family and their community. And so we'll be examining some of these aspects in a way that we do have sort of a familiarity with what happens in pandemic diseases. Now I'll take the next slide. So there's been a debate among historians. Should we look at the Black Death and the plague? Is it more like that? It's very hard to go back to a time where our understanding of processes of disease and our ability to intervene seems so fundamentally different, but the Black Death led to the death of perhaps as much as a third of the world's population, just a devastating pandemic. Many people argue the world's biggest. While a lot of people have looked to the plague and Black Death as an analogy for COVID-19, and there are similarities, the use of masks, for example, the use of medications. Others have pointed to fundamental differences. I'll take the next slide. These are just remains from archaeological diggings. This is a slide from indigenous artists who documented smallpox in Mexico City in the 16th century. And one of the things we'll want to look at is, how does disease get represented? What are the photographic, in this case, or artistic or literary notions of how to represent what is happening? I'll take the next slide. Most of the analogies to COVID-19 have often centered, as many of you have read, on the pandemic that swept the world in the period immediately after the First World War, 1918 to 1920. It's been estimated that as many as 50 million people around the globe died during that epidemic. Probably about 600 or 700,000 Americans, a devastating epidemic. There's been a lot of discussion about, is this the next Spanish flu? Will it be as devastating as Spanish flu was, one of the biggest epidemics in human history? Next slide. You'll see in these slides notions that a lot of people have looked back to about medical care, distancing, avoiding infection. We can say more about this later in the course, but very big fights about shutting down businesses, churches, schools, very big fights in 1918 and 1919 about requiring people to wear masks on public transportation. So next slide. These are two nurses in Boston, 1919. And one can't help but see this and reflect on emerging iconographic images of COVID-19 and the difficulties of protective equipment for healthcare workers and the fears of contamination and contagion that have characterized our own moment. Next. I was struck by this when I found it a couple days ago, because I'd seen so many photographs of people opening up hair salons and barber shops on the streets in Los Angeles and New York and Miami. And this is a slide from 1919 of a barber shop going outside to the street. in many ways like we're seeing now. I think in almost all of these images, I could have found a paired image for COVID-19. And next. One of the things that's very significant about 1918 and 1919 was beginning to develop visual ways of explaining pandemics and epidemics, and the beginning of a new metric of pandemics. And this slide represents that. These are mortality slides for Europe and the US during that period. And a lot of people have looked back to 1918 in particular in talking about flattening the curve and how to mitigate a pandemic to lower rates of illness and death. Next. These look very similar to things you might see today or recently in the New York Times or on CNN or other news vehicles. I wanted to point these out because already during the 1918-1919 epidemic, public health officials were collecting data related to race and showing that Black people were more vulnerable and died at higher rates than did whites during the 1919 pandemic. And one of the things we will really want to center attention on in the course is the issue of vulnerability and the role that racism and social inequality play within the context of any epidemic disease. Next. The notion of flattening the curve really emerged from people studying the 1918-1919 epidemic and observing that in communities that social distanced and developed strong policies and lockdowns, that they actually had more moderate epidemics in that period. And often a comparison is made between Philadelphia and St. Louis. Philadelphia, which never really developed formal social distancing, had a much more serious pandemic than St. Louis. But there's ambiguity about this data, but it's something that we're going to want to focus on. And we're going to want to focus on how data is collected, how it's reported, how it's visualized. And these, I think, are all essential questions. And they speak to the larger issue of developing a more sophisticated awareness of the social forces that determine how we understand what a pandemic is and how it's affecting us. Next. This is just a representation that all of you have seen. Flatten the curve. Flattening the curve would make it so that our healthcare institutions were not overwhelmed and perhaps reduce deaths. And we've seen a lot of debate about the curve, its flattening, surges, and we'll be following very closely as we go what's happening with the epidemic during the period that we're investigating right now. And next. This is maybe not as clear. I don't know if everybody can see it, but one of the big debates that historians got into in the last few months was how significant will COVID be in relationship to epidemics of the past? How does it relate to the Black Death or the influenza pandemic of 1919, 1920? How does it relate in terms of the impact of other epidemics of influenza during the 20th century, or to especially HIV, a catastrophic epidemic of the 80s and 90s, which is still an important cause of suffering and death around the world? And people have asked me, when do epidemics end? And how did the HIV pandemic become routinized, and how has it become no longer a focus of crisis and emergency? And this is an important question we will want to ask. But what I found when historians try to make these comparisons or these analogies, they typically fail. And I think they fail for this reason, is that ultimately we can look back and say how many people died in a particular pandemic and have some crude estimation of what that is. But that question undermines this, I think, more significant set of questions about experience, response, and outcomes that is not just an issue of trying to estimate how significant an epidemic is. One of the things we know right now is that COVID-19 has disrupted our global life in fundamental ways. And it's not just an aspect, although it's important how many are dying, but it has disrupted lives in profound ways that we need to understand. And I think if we only focus on how many, we might miss some of those critical issues. And it doesn't really tell us that something's more or less important. It tells us something that's really crucial about the history of disease. And I'll take the last slide now, which is that every pandemic can only be understood in its context. And it can only be understood by the decisions that people are making in real time to try to change its course. And that's what we would call contingent decisions. And one of the things we're seeing about COVID-19 is it plays differently. It plays out differently in many different places in the world, depending on their resources, their economy, their science, their ability to access care. And so we really want to focus on this question of what is the context. And one of the things we're finding, you're scattered in many different places, is that in some of your communities, many people are adhering to wearing masks and other communities not. How do we explain that? What does it mean? And we also know that leadership and the ability of institutions, of the state and beyond the state, and institutions that cross state boundaries like the World Health Organization are crucial to how we respond to epidemics. So we also want to study what's contingent. What have we done right? What have we done wrong? Where has leadership failed? What are the different ways we explain the pandemic, from conspiracy theory to sophisticated immunology and virology? So these are some of the questions that I know that Dr. Katz and I will be asking our speakers, but these are also questions essential, I think, for all of you as we try to make sense of something that is so profoundly complicated and intricate and humanly important as the pandemic. So I will stop there and turn it back over to Dr. Katz.
Thank you. Do you mind if we move to the next slide? And I just want to say, you know, one of the great pleasures of getting to do this course, besides exploring this with you all, is the opportunity to work with Professor Brant, who, as you all probably know, is one of the most renowned medical historians out there and has covered many of these pandemics himself in terms of his work and research. So our hope is that you'll hear really a wide range of both opinions and perspectives in this moment. And I am tasked in the next probably about 10 minutes to get us all up to speed about where we have been and where we are headed in this moment in COVID. So may I have the next slide, please? So as probably all of you know, in December of 2019, so this is, again, it's less than a year ago, a cluster of cases of pneumonia emerged in Wuhan city in central China's Hubei province. And you can see here genetic sequencing of isolates obtained from patients with pneumonia identified a novel coronavirus, which was 2019 nCoV as the etiology. And as you notice in this map, the timing of this outbreak, well, you won't see this here, but the timing of this outbreak was unfortunate in the sense that it was Lunar New Year. And so a lot of people started to travel early on before we understood how contagious this virus could be. And looking at this map of travel, you can see how quickly this virus spread. And this was something that for those of us who are in public health, in ID, which is my specialty, really were starting to look at this early on. This was a deeply concerning time. And as we moved through this period, by January 13th, we had the first reported case outside of China, and that was in Thailand. And you can see by this map the spread and the nature of global travel. And this is something that's different from those earlier epidemics, that we now can be anywhere in the world within a matter of a day or slightly longer than a day. And so this is how epidemics become pandemics and travel. Can we have the next slide? Great, and so you can see here what we talk about when we think about exponential growth. Exponential growth means it's growing at a rate that has a higher multiplicative value. So with each case, you have larger numbers of cases that grow. And this is just in Wuhan to show you how quickly this virus started to spread around the community. So this is from early in January out through April. Okay, next slide. And I want to show you, before we start the actual graphic of this, I want to show you, just pay attention to the date. This is now February of this year, and watch what happens as this pandemic explodes. Go ahead and hit the play button. So you can see the spread through Europe, the spread through the United States, the spread through Latin and South America, Africa, South Africa being a massive place in Africa with a large amount. And look how consistently the United States shifts over to be one of the largest epidemics now in the world. So again, thank you. And we can hold here just for a minute. So I couldn't stop that as we went through, but just to give you a sense of the time frame. So by early February, we had about 20,000 confirmed cases in China, and an additional about 160 in about 23 other countries. And this, at that time in early February, included about 11 in the United States. It's hard to believe that was just in February. And you can see how rapidly this took off. This is something that is probably once in our collective lifetime. And it's important to be aware of this moment and this context together. Okay, feel free to advance the next slide. So this is just, again, a visual of these cumulative cases that took off in terms of both the United States and the world. And you can see that the US really anchors a much larger proportion of the global cases right now than almost any other country. And when you think about China, which is where this all started, you can see there's a real difference in this moment. And this is a graphic from data right up until a few days ago. The United States just took off in terms of what has occurred here. And we're going to really explore this together. We're going to have public health experts, epidemiologists, to really unpackage what happened here in the United States that may be different from other countries. Okay, great, next slide. Great. And this is just something I thought was really interesting. This is called a transmission network. And this again shows the transmissibility of the virus coupled with human mobility. And it's really what got us to this situation that we're in. So researchers use something called viral genomes that were collected and shared around the world. And one of the really exciting things about this time is how collaborative the research community has been with one another. So there's been a lot of sharing of sequences of genomes and ways to help identify cases as they move throughout the world. So I just thought that this was an interesting way to visualize the transmission of this virus as it moved from one country to the next, back and forth, global travel. And you could see this based upon people's genome. And we now have over 25 million cases in the world. As if I looked at the map yesterday, over 25 million cases of coronavirus, and over 850,000 people have died globally. As I mentioned, the United States is anchoring the largest proportion. They have 25% of all cases in the world and 20% of attributable deaths. So this is a massive, massive pandemic. Okay, next slide. And part of the reason that this really got hold so quickly globally is not just the travel, but the way that we convened. People came together it seems like years ago now, but back in early March, people were still meeting with one another. I was personally at a meeting where I was actually exposed to someone with COVID. It was a global health HIV research meeting, and someone came in from another region of the world and moved on, but happened to be asymptomatic and had COVID. And so this happened all over. And here in our town of Boston, we had the Biogen Conference. And many of you, I'm sure, have read about this in the news. The Biogen Conference was really an epicenter for an explosion of COVID in the Boston area, and then that ultimately spread because people came together from all over the United States and even the globe to come to this conference. And what's so fascinating is right after this conference, maybe 2 weeks later, all sorts of meetings in person shut down. So you could see how quickly this was moving. Great, we can move on to the next slide. So I just wanted to briefly touch on the fact that there are people on the front line. I am one of the clinicians on the front line. I work at Brigham and Women's Hospital, and of course, work with colleagues throughout the hospital. Everything changed radically at the hospital in early March. This was a time that really none of us had ever seen. Certainly hospitals were one of the best places in the country for healthcare, and hospitals were certainly well prepared for an emergency, but this was an emergency of epidemic proportions. So we all had to quickly learn how to don and doff PPE. You can see an example here of someone who was putting on what's called an N95 mask. This is a more protective mask than a surgical mask. And we can move to the next slide. So this is me. You might recognize me or not. This is what I wear when I see patients at the hospital. This is for patients who are not considered to have COVID. So this is our bare minimum now of what we wear at the Brigham and also at MGH. This is a surgical mask, so not as high filtrate as an N95. Probably most of you see this on people walking the street. And now we're also required to wear face shields, again, for people who are not suspected of having COVID. For people who are suspected of having COVID, we have much more advanced coverings that we use, including the N95 mask. And again, I just want to highlight, this transition happened so quickly. It went really from an operation that was, living in the background, because hospitals are always prepared for emergencies, but really nothing, into full steam ahead within a matter of a week, that we all physicians had to get, and nurses, and any frontline provider had to get trained to use this. And again, if you were looking at the news, you saw the outbreaks in New York City. We were prepared for having something very similar here. We were having conversations about whether people needed to be taken off of ventilators if they were critically ill. These are very disconcerting conversations to be having as physicians, and we were having those discussions. So next slide, please. So this is just a quick graphic. You can go ahead and start to play it. I want you to watch COVID-19 and the time frame here. This is daily mortality in the United States. Look what's happening with COVID. This is just into April. And to this day, COVID is now sitting in the top 3 killers in the United States. This is unbelievable. And you see how quickly that transpired on a daily basis. So we need to be, as clinicians, aware that any patient who comes into our hospital could have COVID, could have been exposed to COVID. And we know that people who come into the hospital for other reasons often are at highest risk here. So next slide, and then I want to wrap up. So this is just, again, Professor Brant highlighted this, that we are seeing dramatic differences across race and ethnicity, and that Black and African American patients are certainly at highest risk for bad outcomes from COVID. And we're going to really unpack the issue of race in our society. Let's move to the next slide, just in the interest of time. This is just a quick map. I'm going to orient you in 1 minute The Harvard Global Health Institute populates this map every day. It gives you a sense of where the epidemics are at the county level. You can log into our website or through globalepidemics.org to see this. It gets updated daily, and you can see where we are. We're in the yellow right now in the state of Massachusetts. Green is go, red is the highest rates right now. Okay, next slide. And this will be the last slide that I show you. I want everyone to think about in your own mind as you predict forward. This slide cuts off, this is data from IHME in Seattle that looks at the trend. Think to yourself as you're moving forward, where do you think we're going to be when this course ends on this epidemic curve? So with that, I recognize we're just at the end of our time, so I want to pass it back. I think those are my slides. I know we didn't have extra time. We wanted to do some polling and some time for questions, but I also want to be respectful of people's time. Professor Brant?
I think we'll end here just with the notion, and, you know, I found these graphics of the pandemic, you know, incredibly sobering and significant. One of the things we're all aware of is that epidemics are a moving target, and we're going to be watching those changes and their implications as we go. I think it's best to end today's class now, but with the notion that if you have any questions, specific or general about the course, please feel free to be in touch with any of us, and we'll try to get back to you as quickly as we can. And we do have some polling questions that we want to ask you. We want some baseline data about how you're thinking about the pandemic, and we'll do that when we start again on Tuesday. On Tuesday, we have a really fascinating group of visitors. It's a number of Harvard faculty and administrators who were involved in the decisions about how to reopen Harvard this fall, and in fact, how to close Harvard last spring. And we thought this would be a great way of starting the course, because the questions that they worked through with other experts about what's safe, what can we do, what should we be very careful about, what's the relationship of remote to on-campus life, all have been critically important, but they reflect much broader questions about where we are in the pandemic. So that will be Tuesday morning's session. And just to say again, I look forward to meeting all of you and seeing all of you, but we're really looking forward to getting to work with you during the coming term. Dr. Katz.
Thank you so much. And again, it's our pleasure to be here with you. We can stay a little bit after if people have questions, but we also want to be respectful of everyone's time, and just thank you all so much for coming.
We'll see you all on Tuesday.